Hello everyone. Welcome to another webinar from the Steps Forward Innovation Academy. Today we'll be discussing caring for patients with complex chronic conditions. Over the next 45 minutes, we'll discuss how to provide proactive whole person care for patients with complex chronic conditions. We'll explore strategies for addressing social, mental, physical, and spiritual determinants of health, developing personalized care plans, and coordinating care through a dedicated advocate, all designed to reduce costs and improve outcomes within value-based care arrangements. Please note this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. Without further ado, let's go ahead and get started with today's webinar. Joining us later to moderate the Q&A will be Dr. Marie Brown, Director of Practice Redesign here at the American Medical Association. But I'm about to pass it off to our speaker today, Dr. Wayne Jonas, President of the Healing Works Foundation. Dr. Jonas, take it away.
Thank you very much, Eric, and it's good to be here. And hopefully what I can do is draw from my experience, which is listed here for your viewers to see. I won't go into that. To really talk about a system that we've developed. First, it was done in the military, then it was drawn from and integrated into VA care. And then we pulled the tools from those two settings and brought them out into non-federal settings, out into the regular practice setting, and tested them with 16 different clinics of a variety of types, both specialist care and primary care around the country. Then subsequently looked at some of the same tools for those who are involved in oncology in 13 additional clinics. And you'll see in the resources the publications that have resulted in that. And what I hope to do in this seminar right today is really sort of give you an overview of what those tools are and how you can begin to explore embedding them into your own practice to make them available. Now, the reasons for doing this are multiple, but I'll give you the basic bottom line on this. We all know that patients with chronic complex diseases are complex and often a challenge. And as healthcare gets more complex in itself, more options, more management problems and challenges in these areas, it becomes often very difficult to help people with chronic diseases manage their own conditions, as well as improve their own conditions and prevent them from getting to be very high cost and high care utilizers in those areas. And the risk of that is significant. Most practices, between 5 and 10% of the patients they deal with end up costing about 80% or spending about 80% of the healthcare dollars in these areas. And so if we can prevent or even reverse some of these high cost, high utilization chronic care, we can, by improving their health, improving their care management, then this benefits both the system that you practice in as well as the patients themselves. So what I'd like to do is I'd like to take you through the steps that these and other clinics, ours and other clinics, have used to identify the right patients to do these kinds of visits with, how you actually perform such a visit, how you then select the measures or the outcomes you want to see if you're having the impact in those areas, and then begin to track and improve your practice in ways that bring more patients into this if they're appropriate, and then streamline those components so that you can do it in a routine way. Let's see now, there we go. So this is only one approach to whole person care, but what we have found in utilizing this in clinics around the country is that it's actually a very simple way to do it and to target the particular individuals and particular patients that need it the most. And that's by focusing on those that are likely to be high cost, high utilization and complex patients, which are some of the patients that many of us have the most challenges with in our fragmented system in those areas. So here are the basic steps on how to do that. First of all, you need to know how you're going to get covered. And this is often the last question people ask, but I think it's the first one you should look at in your system, because you do need to get these types of services if you're going to expand those services, or at least the coordination of what's available, and get the time and the attention and the management covered in those areas. Second, you need to identify the population that you want to focus on. And there's a variety of ones. It really depends upon your practice, and sort of set up either a cutoff or a selection process to identify those populations. Train the team on how to have conversations with those patients to educate them about this type of care, and have an advocate or a coordinator, if you will, that really makes sure that the team knows all of their roles in doing this. Then enroll some patients and schedule some of these high value, or what we call whole person care visits. Try them out, make some adjustments, measure the outcomes, including the satisfaction, and then improve that before you widen it to a larger population. So let me give you an example of how we do this in my practice. We have focused a lot on chronic pain patients, especially those with opioid use that we'd like to get down. And here's an example of a patient, 64, I'll call him Joe. He had a car accident over 15 years ago, and he developed a very common problem that we see with many patients, chronic low back pain that persisted. He went and did a lot of things. He got x-rays, MRIs, he started on NSAIDs, physical therapy, TENS, injections into his back. He eventually had surgery twice. He ended up on opioids, which he got addicted to. He then was referred over to behavioral medicine and went into opioid recovery to get off of those. And the question is, here's a complex patient, very high care utilization. How do you apply a whole person approach for somebody like that living with pain? So this is the kind of patient we selected for these kinds of this kind of high value visit. And we sat down with Joe and we started with a set of tools, one called the Personal Health Inventory, or PHI, and then a way of documenting that discussion, which we call the HOPE Note, that parallels and supports the SOAP Note for his clinical diagnosis. That stands for Healing-Oriented Practices and Environment. It's a set of questions that come out of the PHI that make it easy to have a discussion about the non-medical components that were preventing Joe from improving his back pain in those areas. And here's what came out of that discussion. He needed extra help in medication management. He wanted to use less pills and procedures, but he needed someone that could actually go through a confusing array of prescriptions that he had on the table and that he was probably not complying with very well. He needed some help in the primary non-drug approach that seemed to help him. That included heat and stretching, but he needed to have it set up so that he could do it regularly at home, not just come into physical therapy. He had some significant things not normally related to or thought about for chronic pain patients. He had problems with sleep, and he had some major stress problems. So we needed to specifically focus on those and help him with stress management and sleep management. He needed to be able to do this in his home. We needed to get him engaged in this process. And to do that, he had to have a reason other than the fact that he had medical appointments that engaged him in more self-care and engagement and support. And in the discussion, we discovered that one of the main reasons he wanted to address his back pain was so that he could get in the car, drive down, see his grandkids, get down on the floor and play with them. So this was his life reason for wanting to improve his back pain. So embedding that purpose as the primary goal then became the focus of what was done with him. Now, over a period of only about 3 to 4 months, we were able to help him embed these into his routine. keep him focused on the reason he was doing it, build up his core muscles, address his sleep and stress, heat and stretching, and automatically he began to use less pills and procedures, less healthcare utilization, improved his back pain, and accomplished some of those goals. So that's an example of a patient. We'll go into that in a little bit more detail about how that kind of thing works in practice. So here are the basic steps I mentioned to you in terms of doing this kind of care. Number one, you need to know, how are these patients currently billing? How are you billing to take care of these patients? And are there alternative ways that engage these non-medical approaches that then are going to help people heal? And here's a list of some of things that you could bill for. You need to get your business folks involved in this so that you're doing it right. Possibly at annual wellness visits. There are group visit codes to help people engage in group visits. A lot of this kind of care is done very nicely within group visits, if possible. Education and training for self-management. There are new medical management and complexity codes within Medicare and others, and there are some old ones that can be plugged into this. Some of the telemedicine codes, caregiver and support and training, and navigation codes in those areas. So find out what your patients are doing now, and where are the business components for coverage of this type of services that you can then set up. Second, then, is to identify what population you want to try this out on. I just gave you an example of someone with chronic refractory back pain, but you may have others that are at high risk and high cost, complex patients, high utilizers that you want to focus on. There's a variety of ways of identifying those patients. You probably have already in your practice the ability to do that just by looking at your population. But here's an example of some tools that can be used to select out the key patients that you offer these kinds of whole person care visits with. You can see a list of those there, but again, there's a variety of ways to do that. If you're using some of these tools, you have to set a cutoff in order to find and identify those patients in an appropriate sized cohort. Then you need to train the team. A lot of this involves training either a health patient navigator or an advocate that has the flexibility and is given the authority to help connect to some of the services that the patient may need, whether those are mental health, social services, motivational, medical decision-making, or just simply care coordination with other specialists and other referrals. Here's a list of examples of the kinds of things we have in our practice that allow you to bring them in, train them about how these patients are going to get managed so that people know what their roles are, and that the management and the navigator has the authority to work with them. Then try it out. Start to select and enroll some of these patients. The invite should come from the primary clinician or the physician because that's important for most patients. They want to know that the physician is on board with this. But the physician doesn't have to actually do all of this. In fact, it's the team that does it, and the coordinator or advocate that does a lot. The explanation of why they're having this kind of a visit through a personal health inventory is important. There's resources now available for doing this electronically, or you can embed them into your EHR. The physicians find, in our experience, is that even though they say they don't have time to do it, once they've done this a few times themselves, they actually like doing it. They get to know the patient in ways they never knew them before, and they're facilitating access to the drivers, the personal determinants of health that they know are there in those areas. So they actually feel good about it. It's more person-centered in many ways. So many physicians like to do it, but they should at least be involved in blessing or advocating the process and making sure the team is executing it properly. So then you want to know if it works, what you've set up works, and so you need to make sure you collect and use data. So use the standard PDSA practice improvement approach that hopefully many of you are familiar with. Start small with a pilot project so that you can better understand whether you've selected the right population, whether you've coordinated the right resources to make this efficient, and then make some clear metrics that you can collect and track from the things that are important to you and your patients and your practice. Then once you've engaged in that, collect some comprehensive data over a period of time, and then come back, step back, look at what that impact has been to make changes in the program in those areas. And again, the standard practice improvement component. So let me illustrate this in an actual practice. This was done at the Jamaica Hospital Medical Center in Queens, one of the most diverse areas and populations in the world, actually. And they had many patients that were complex. The insurance issues were complex. It was mostly Medicare, Medicaid, or non-insured in those areas, although they did have a few capitated contracts. And they wanted to do this kind of thing in a particular population in those areas. So the first thing they did was understand, where was the money going? Where were these patients going? And so they tracked the kind of services, as you can see listed here: emergency visits, hospital admissions, overutilization of services and testing, and overutilization of drugs. And they identify these as some of the sources that these patients were using. They did have a subpopulation to test this on that had globally capitated patients, about 50,000, and this is the population they decided to draw from to do and test whole person care. The way they identified population was by using a tool looking for those at high risk for high cost. It's called the Converging Health Whole Person Risk Score. What they found in using this tool is that there was about 8% of patients, as you can see circled, who were in the high risk, high cost area. And these were the ones that were utilizing all of these services that listed before. And they said, these are the ones we're going to focus on a whole person enhanced care visit. They called it a high value visit for those patients. So here's the team that they put together. It involves 7 faculty members, 2 physicians, 6 family medicine residents. They had health coaches and health navigators that they had trained, and this was in many ways the heart of the program to help in terms of the coordination, to make sure that the individual needs of these complex patients, whether they were social, psychological, or behavioral, were addressed. And when those needs were needed, then others, as you can see on this list on the left-hand side, were brought in. But the whole team was trained in these special high-value or whole-person care visits. Here's what went on in those visits. The patients were given the personal health inventory. It's a 2-page questionnaire in which the focus is on what matters to that patient, what's important to that patient, what are the needs that they have. It was holistic in the sense that all of the major drivers of health, including the non-medical ones, were discussed. This includes not only what their diagnosis was, what was going on in their body, but any kind of behavioral lifestyle aspects that could assist them in improving their health. They were asked questions about their social and emotional aspect, and this was independent of whether they had a mental health issue or not. And again, getting at the core goals of why they wanted to have health, the spiritual and mental component at the center were discussed. So again, the tools that provide this allow for a rapid snapshot of these components so that you can zero in on what the key issues are that need to be addressed. The resources to help them move along in their healing path had to be there. I call those salutogenic instead of pathogenic tools. The pathogenic ones are almost always done in these patients. You know what their diagnosis is, you know what their healthcare utilization is, but what you want to know is what are the personal drivers of health and healing. And how do you access people to those services? And this is what the tools are for. This is what the navigators, advocates, and coordinators were. So they began to enroll patients, and they drew them from this particular population I mentioned, and they began to coordinate care. And you can see some of the list of people involved in that process. They embedded the Hope Note tools into their electronic medical record, which was Epic, and began to have a pull-down menu for these particular patients to coordinate the care. After 2 years of trying this out, they did some pilot projects first, but then a formal project. They identified those who were at high risk, and this is the scores from the whole person risk score from Converging Health I mentioned. And as you can see, those in this advanced practice model, the whole person care model in purple there had significantly higher risk and higher costs. And over the 2 years, they were able to bring those high-risk patients down into a more average risk score that they saw in those areas. Over that period of time, they found a reduction in risk of approximately 19%, according to that score, compared to the usual care clinics. The cost decreased by 22% for each patient over that period of time, saving the system close to $12 million or over $3,000 per patient. So what does all this mean? I've given you the basics of it. I've talked to you about the key tools. So what might you do on Monday? Well, there are at the end of this seminar and in the resources publications about how clinics have been doing this. I've given you an illustration of one around the country. There are also CME tools that are available, as well as the personal health inventory and other kinds of resources, pocket guides and things like that for patients and clinicians that are available. So I'm hoping that after this seminar, you'll try some of these things out. These are all available and free from our foundation and other places, and see how it works for your patients. So I'm happy to answer any questions that people have and have a discussion about the nuances of how this is done.
Great, Dr. Jonas, that was absolutely fabulous. And you covered a lot of information. You have so much experience, and the breadth of knowledge is amazing in a very short period of time. So it gives us a lot of time for questions, and they're popping in. And let me introduce myself to the audience. I'm Dr. Marie Brown. I'm an internist here in Chicago with 30 years of practice, often with many complicated patients like yourself. You're in family practice. And those are the flow busters, we call them. You see those patients that not only receive care in the emergency room, but they interrupt your day-to-day, distract you from your patients that you're trying to care for at the moment. And those interruptions are not reimbursed. Again, they're unscheduled. And the cost is huge, right? So it's not just the cost of that individual care, it's really to that patient, as you say, but it's also the cost to you personally. And I loved when you said that if you don't do this, it really drains the joy from our practice, because we know we're not meeting the needs of the patient. So lots of questions, and I love that you started with step one. This is all wonderful. We all hope we can do this, but how do you pay for it? Yeah. So the first question in the Q&A is, can you tell us more about that? And that's what our administrator and our hospitals and our clinics need to know. How do we pay for this? So if you could dive a little deeper into the payment model, that would be helpful.
Yeah, and I think that is important. It is key. You have to be careful that can't be the only reason that you're doing this. It's not the primary reason that you're doing this. You're doing this to try to actually take care of patients in a way they need to be taken care of, so that they can get better, they can feel better, they can get managed, and they no longer become these high-cost, utilizers that are using all these different services from different groups. That's the primary thing, is to improve the quality of care and improve the outcomes and the clinical outcomes. Now, that being said, you have to be able to cover it in those ways. And I'll be honest with you, it's not straightforward. When you're doing, you're addressing the chief complaint, you go through your SOAP note, have a billing code, et cetera, you know how that works. Your business is set up to do that kind of thing. And but if that's costing your system a huge amount, or if you're in a value-based payment system, that is going to end up costing you a whole lot more than what you need to, because it's inefficient when these people come back over and over and over again in those areas. So this is selecting out individuals and then coming up with payment models. And I listed a number of those. And on our website, we actually have a payment guide, which actually describes what are those codes, how are they done, and how do you begin to cover these kinds of high value visits for those selected populations. Now, the ones that you use depend a lot on which population you're actually dealing with. Okay. With chronic pain patients or patients with obesity or diabetes, there are certain codes that you can use in those particular areas. With mental health areas, if those are major, there's other codes. But then there's some management codes, as I mentioned before, and the recent physician fee schedule has expanded those management codes. We're still testing a lot of those out, so some of them are worth it, some of them aren't, but at least now there are some codes that allow you to put into billing automatic complex patients like this. So make sure that your business group knows what those are, set up those areas. Group visits are extremely useful and actually, can make some money, but you have to be able to, have someone who's going to run those group visits in order to train and educate and engage patients in their own care in those areas, and you need to know how to bill for that. There's ways to do that with health coaching. The Jamaica Hospital System illustration or example that I gave you there had health navigators already embedded in their system. They were trained mostly in trying to help people coordinate their own care and appointments and visits and referrals and that type of thing. And they trained them in some additional skills around engaging the patient with motivational interviewing and behavioral change components in those areas. And those additional skills then could be added and made available in those areas. And then they had a payment code for providing that. So they had to set all that up there. Some of the supportive services, non-drug approaches like, for chronic pain, I'll give you an example. Acupuncture for certain types of pain is very useful. Yoga, et cetera, are evidence-based. They're in the guidelines right now. And so having those either available in your system or in the community, where you can then refer people off into the community, is another way to help cover some of those. And so setting that up really depends a lot on the environment and the system that you're in, the resources that you have already, and building on that to identify the particular payment way to cover that.
Right. And I think you highlighting that we already have many of these resources. We just haven't structured it for the patient's needs. So you were the director at the NIH for alternative medicine, along with other roles, and finding and embedding physical therapy into, these people are so complicated that when we look at all that we're doing, just putting out fires, oh my gosh, they're not even going to physical therapy, or the physical therapy that we sent them to is too far away, right? Oh, we could get it in their home. So the resources are there. And I found in my practice that if I had a good physical therapist that connected with that patient, that physical therapist functioned like a coach, almost as a psychologist, right? And it made my experience so much more joyful.
That's exactly right.
Yeah. Go ahead.
No, no, I'm sorry. I didn't mean to interrupt. That's exactly right. This is exactly one of the things that helped Joe, actually, the case that I illustrated do this. He was going to physical therapy. He had been to physical therapy, and they'd put him through the routines. You'd write a little prescription. They'd run up there, et cetera. But it was very limited, and it didn't necessarily adapt to what he needed in his life goals. It was like, putting him through torture, and he often then wouldn't go back, right? What we did after we determined that what he really wanted to do was to get down on the floor and play with his grandchildren, we then connected with a physical therapist and said, Joe's willing to go through some pretty rigorous stuff if you can get his core muscles, okay, functioning so he can get up and down off the floor. And the physical therapist, once she understood what it is he was trying to get to, okay, from the visit that his physician blessed, then he started coming every single time. He was going through some very difficult strengthening and training. She loved it because she saw the progression and the improvement going on. So the resources already been there, but it hadn't been connected to what was important to him. And once it was connected to what was important to him, then it began to take off, as well as some of the other supportive things I mentioned before.
Yeah, fabulous. And some other questions coming in. Who gets to be or is qualified to be a team coordinator? And that's followed by another person asking sort of the same area. Are RNs used in any of the navigator health coach roles, or are they social workers, medical assistants, mixture of the above? Maybe you could address the roles.
Yeah. No, that's a great question. If you, let me make sure I understood the question. Was it about group visits or was it about team coordination?
Team coordination.
Team coordination.
Or navigators specifically?
Yeah, so it depends a bit on the size of your practice and the size of your system. And it depends a bit on the skills of the navigators, okay? In the case of Jamaica, they already had navigators. They were trained at doing exactly what navigators do, which is help you coordinate through the system. They were serving the system. Some of those individuals were extremely good at connecting with the patients and helping to coach the patients. So those were the ones that were offered additional health coaching and given the additional authority to work with the patients to do the motivational interviewing, to get them engaged in finding out what matters, in terms of their particular personal drivers, et cetera. And those were the folks that were given the authority to do that. Now, eventually they set up some nurse coordinators who supervised those folks, but they provided that additional training in those areas. And others, those were the ones that were given the high value visits, the ones that could make that connection with the patient and knew the system sufficiently enough to be able to do that. And it's interesting, we looked at two different parallel systems that were going on up in Queens. Both had navigators. One had pulled out individuals that could make this connection with patients and find out what were the key drivers of their own health or lack of health care management issue, if you will, and others who were just called standard navigators. And one became an advocate, which is why I use the term the advocate for the patient. And those were the ones that had the additional training and the additional role that were given in those areas. And the team had to be trained to make sure they were respected and their opinion was respected. So in the morning report discussions around these kinds of patients, the navigators actually were the ones that knew the patient better than anybody else. And often the decisions about what was needed and what kind of services that were supported came from them. And so there was a subset of the navigators that had this additional coordination training for those high value visits.
Before we move on, there's a lot of questions in the box. How are the navigators? How do you pay for the navigators?
Yeah. So
what's the payment model?
Right. So the payment model varies from system to system. Very often navigators are already paid. So you already have a set of navigators out of which you can select individuals to do this kind of more whole person care. And so, a good chunk of their support is navigation and is already paid for. To the extent that they have to get engaged in what I call health coaching components, our health coaches working with the patients around things like motivational interviewing and behavioral change and engagement. This has a health coach role. There are actually ways to pay for that. Again, we have some resources on that, on which, how it can be billed. Usually has to be billed underneath, a physician care. The clinician, can do management codes if necessary, but some of the health coaching components can do that. And we point to some companies, I won't name them right now, some of them are private, some of them are not, that actually will train people in how to pay for and bill for health coaching. There is a national certification organization that certifies health coaches to make sure that the training around things like motivational interviewing and behavioral change are part of it. But it often comes off, and in the case of the example that I showed at Jamaica, it starts with either the health navigators or often the social workers are already doing some of this work, but with the additional training around lifestyle and behavioral change and patient engagement.
Fantastic. Here's a question. What is the average time associated with a high-value visit?
So a high-value visit takes more time than your 20-minute visit that you're going to get. No question about it, especially at the beginning. Sometimes it goes very, very quickly. The personal health inventory, this questionnaire that I mentioned, a 2-pager that patients fill out ahead of time if they can, or if they're in the office, you can give it to them. It takes them, 10 minutes or so to fill out. That's a great discussion point to allow you to focus in on what's the most important thing that this person needs at this time that is either preventing them from getting better or that is interfering with their ability to comply or to get engaged. And so I like to set aside 30 to 45 minutes with a patient if I'm doing it myself, okay? That again is something that if you focus it in on a population where the management issues are complex, and I've illustrated that with some of the chronic pain patients and others in those areas, you can cover those kinds of costs for that. And that often then, if done right, will prevent the recurrent and high care utilization in some of the other areas that we talked about in those areas. Sometimes I don't have that amount of time, but people want to get engaged in the process, and I will give them the personal health inventory, and then we'll narrow down and have a discussion about what is the primary thing that's most important to them. In the case of Joe, it was medical management. Okay, so we got him engaged with our pharmacologist to go through and help him learn about and sort through and actually eliminate some of the medications he was on. With others, what may pop out is something like nutrition or like activity or often sleep or stress, and then we will pick that one service out and get them plugged into that process. And that type of thing can be done within a short period of time, a 20-minute visit.
And I think your experience taking care of these sorts of patients shines through here because we can't meet all of their needs in any amount of time, right? 3 hours. So asking the patient and recognizing they had many issues, and then which one of these do you want to address today? And if they get to select, and it's often different from what you and I might think we want to work on, right? We want to work on the hypertension or whatever. That's not what they want to work on. And then agree that, how about if we then talk about this other issue at another visit? Would that be all right with you? And that brings joy to the physician because we're not going to be late for our next patient.
That's exactly right. You have hit it on the head there. This is a different framing. This is letting the patient lead in terms of what matters to them and not getting too stuck on solving their particular diagnosis at the time in those areas, because engagement is a key part of this and getting them engaged and embedded into those areas. So, that's exactly right. This is why what's important and asking the what matters question and helping them to set their own goals for why they want to have health care is an important part of that. You know, it's fascinating when you ask questions about them as a person. Patients will light up. They're so happy to be able to talk about this. When Joe started talking about his grandkids and the frustration he felt about not being able to actually sit down and play with them in those areas, this then was the hook, okay? And I might have wanted to change his medications up or, you know, get him on, a different physical therapy regimen, which we eventually did in those areas. Or I could see that stress and sleep was a huge issue that was preventing him from getting better. But what he wanted and following that lead got him engaged in those kinds of things. And that can be done, quite rapidly in those areas. So stepping back and really taking a person-centered, not a patient-centered, but a person-centered approach that incorporates this holistic component that I was referring to in the visit, that allowed for any of the personal drivers of their health or healing or lack thereof and what those obstacles are, and then starting with the one that they say is the most important. And so they may have a list. On the personal health inventory, they rank these things from 1 to 5 as to what are the major issues for them. And I start with the one that they say is number 1. And that's the one that we plug them into.
And I think in doing it that way, you're allowing them to choose, and they are then more satisfied if they don't get to number 2, 3, and 4, and they'll deal with that another time. So the time-saving approach and the satisfaction both on the physician side and the patient just rises and brings you much more joy. I can tell in your voice how much joy that was to find that and develop that relationship with your patient. It was just rewarding on both ends. I have a comment from another listener. Physical therapists often get referrals so late in the course that the pain and deconditioning is well established. One of their most effective interventions is listening to the patient's story. And I can't agree with that more. Do you find that having protocols or standing orders so that this isn't, the physician doesn't have to think about it, top of mind, but somebody will nudge them to think, oh, have we sent Joe for physical therapy? What's your experience with protocolizing or standardizing some of these opportunities?
I think it's very important to protocolize and standardize this, as long as it doesn't get reduced to sort of a universal checklist that you're trying to apply to every patient, okay? As long as it's got built into it the flexibility, to be able to quickly plug people into the most important thing that they need at the time of that particular visit. But making this routine and protocolized with a stepwise approach, as I described a bit in the practice improvement steps of what we're talking about, is very important. So we, for example, did have a checklist that came out of the discussion and was embedded in the Hope Note, and that was the plan, right? That was the initial plan with the top thing at the top. That plan was made and based on the personal health inventory. And it's not an infinite number of things. If you go through the kind of 4 layers of what a person is, the physical, the behavioral, the social, emotional, and the mental health, which are embedded in the personal health inventory, and they check which ones are important to them, then that makes it routine. And then if your health coach sees that plan that comes out of there, and your team is trained to know that I'm going to get patients referred to this, and that's embedded in the electronic medical record, then these are things that can be routinized. And many of the clinics that I mentioned that this was tested on out there did that. They put it into their electronic medical record. It linked up to some of the services that were available in the community or elsewhere within the health delivery system that they had. And it made it easier for those things, to be delivered. In one of the clinics I worked in, it was done on pencil and paper. That paper was handed to the patient, and that was given to the health coach, health navigator in those areas. And then, again, with the proper training and resources, those things were easily then plugged in, to the healthcare plan.
Great. And I'm going to go through a couple of real quick answers here. And then I'd like to move on to selecting that population and cutoff. But one question is the PHI use restricted by copyright rules, or can we use it freely? I think you referred to that.
Yep. No, it is not restricted. It's totally free and available. I think I mentioned that we adapted this from a form that was being used in the whole health system within the Veterans Administration. And we sort of de-veterinized it, if you will. We made it more generic in those areas. We simplified it, and it wasn't copyrighted in the Veterans Administration. It was, publicly available, and ours is also publicly available. This was the one that was tested out in the clinics that I mentioned to you. And if you go to our website and just, type in, PHI or Hope Note, et cetera, you'll see it. You can download it. You can brand it to your own clinic if you want to in those areas, and it's totally free to use. There is an electronic version that has that we gave to a company that simplified it so that it could be done electronically in those areas. And they have, I think, a small fee if you want to use their software to do that. But the Jamaica system put it into their their local Epic system as a pull-down menu. So it's doable that way too.
Right. And I would say that your website is fabulous, and the videos on the website are great as well. I especially appreciated the change management video. They have some wonderful links, and very generous that it's all open access. So here's another quick question. Who authenticates the Hope Note? Is it co-signed by the ordering provider?
Yes. It's important that the clinician look it over and understand what it's about, and then co-sign it or bless it, once it's been developed, usually by the navigator or the social worker or whoever's doing that intake visit in those areas. So, the note of the plan then gets written out, for that. That's what the Hope Note is. It comes out of the PHI, and it's important the clinician do that and know that. And it's important that when the subsequent follow-up visits occur, that goal that the patient set for themselves, what matters at the top, be looked at first, and the patient be asked about that. They love that. It's like, oh, you remembered that I wanted to play with my grandchildren? Okay. It makes that personal connection in those areas. So it's important that clinician look at it, and that when it's embedded in the follow-up visits, that what matters part is, just as important and easy to access as the chief complaint.
And it brings more joy to the whole team, right? I often would put if the main role now of my elderly patient was spending time with their 8 grandchildren, I'd often put this 75-year-old grandmother of 8 is here for follow-up of, et cetera. But everybody asked about the grandchildren because that's the first thing they saw, and they just light up.
That's exactly right. And guess what? That's their reason for living. That's the mental and the spiritual part of the person, right? Right. And so you've just had an engagement around those deeper, more invisible aspects that are so important to all human beings. So
we're getting a little close here, but I'm going to try to get to all the questions. Population, identifying the population. Many of the listeners may not have the resources, or the resources are busy working on other issues. Are there some opportunities for a small clinic or a clinic within a larger organization to identify those high utilizers, those complex patients in a more simple way? Is it an age group between 45 and 65 on 15 medicines or more? Are there some simple little things to narrow it down to make it bite-sized? Because I think your point about getting a small group, doing a pilot study and see what happens is key.
Yeah. There are a variety of ways to identify the population. I gave you an example of some tools that are out there that are more useful if you're in a fairly large system that's trying to identify patients that may not be known about. In a smaller practice, it's easier because you can just sort through your population and pick out which ones you want to focus on. The example I gave of Joe came from a population that was selected who had chronic pain and had been using opioids. Okay, so we can identify those from electronic medical record in those areas. Diabetes is another one that is often, or obesity is another one that's often, could be focused on or fairly easily identified. Or just healthcare utilization. Most practices are able to identify the patients that are high utilizers, the ones that come in over and over and over again with the same diagnosis, the same problems in those areas, and see multiple practitioners have multiple visits, again, that are in the high cost category. Those perhaps that have been in and out of the emergency room or the hospital, again, those are fairly easy to identify from the healthcare utilization components. But before you identify that, I would really make sure you talk with the leadership within your clinic or in your system and find out, where are the complex patients that are causing challenges and high costs in those areas that they would like you to focus on. And then engage them in helping you to identify the population in those areas. After we did the chronic pain patients in our clinic that I mentioned to you before, we moved on to those that were overweight and began to embed this kind of care in those patients, specifically those who were overweight and had diabetes. So that's an example of how you can sort through these populations in those areas. Another area that we tried some things out with, became a bit challenging, was to embed it in the annual wellness visit for Medicare. That does give you more time and discussions. It is possible to do that. It may or may not be the main population of interest to your practice, though.
Well, that's interesting that you bring that up, because that's another question about annual wellness exams. Are they crowding out sick patients, relegating their care to ERs, urgent cares, and other providers?
Yeah.
So do you see a trend to do the annual wellness exam for the well and not use it because it does pay more? Is that something that we want to keep in mind and use it as appropriately as we can to deliver the greatest quality care? Maybe you could address that.
I think that's a great question. I do not know the answer to that question, whether the annual wellness visits are now bringing in the well and taking up the time, that would be better spent on chronic illnesses in those areas. I'd love to see some data on that. Perhaps that's something you all have information about. Ideally, if an annual wellness visit is also focused on engaging the patient in their own self-care, that it will actually accomplish what the goals of the annual wellness visit should be, which is keeping people out of those other services. Right. So instead of crowding it out and saying, well, there's other people that need it more. Well, why do they need it more? Maybe because we didn't have these kinds of visits that prevented them from, the other needs, that were late stage and were using services that were sort of inappropriate but essential at that time because they didn't get this kind of care at the annual wellness visit. So maybe the question should be reversed. Maybe this is the kind of thing that should be embedded into the annual wellness visit in order to prevent those other kinds of services and therefore have less demand in those areas, in the first place. But
I think that was the intention. We probably have time for maybe two more questions. One question about the proper use of the code G2211. Can you address can you further define the gray areas of serious and complex conditions and longitudinal care?
Yeah. Well, this is something that's getting worked out, right? These are fairly new codes, as are some of the new health, the E&M codes in those areas. G2211, I think any resources that can be embedded in these areas should be embedded in your business components, but they need to be embedded in a way that makes them easy and automatic. I think the reimbursement for G221, once you justify it, is like $16 or something like that. And so, you need to look at, okay, is it worth me spending a whole lot of time trying to figure out when it is, and can I automate this so that if I engage the patient in an area of healthcare management, that the G221 is automatically justified, because it's only going to get me an incremental amount of more money on top of that area. It has to have the clinician involved, okay? So again, this is going to take the clinician's time, and you have to look at your own practice and say, is that particular code going to cover this in those areas? In some cases, if it's embedded within a business framework in which you are covering many of the other costs already, then yes, maybe that's it's worth adding on into those areas and getting the clinician involved in engaging the patient in a way that allows you to use it.
Right. And to wrap up, just another few questions about somebody mentions in the chat about community health workers, and I know our City Colleges of Chicago, where I'm involved, has a community health worker program. Lots of questions about health coaches. And finally, if you could share once again for the audience where the payment guide and some of the other resources reside, so that they can, the listeners can go right there after we finish our Q&A.
Yeah, I think the payment guide, we actually just are in the process of updating it, because as you know, these things change, and in 2025, the physician fee schedule changed significantly, so many new ones have just been engaged. So we're in the process of upgrading it. If you go to our website and then you just look for the Hope Note, there is a payment guide, I believe, for doing whole person care using the Hope Note embedded into that, and it links to that. Or there's a search engine where you can look at whole person care coverage or whole person care billing, and you can go to the payment guide into those areas. I'll tell your listeners, we just give you a list of potential ways that you can do this, because how you do it does depend on the services that you're offering, the population you pick out, and who on the team is engaged in those areas. That will all influence it.
Right, and there can be local variation as well. Yeah.
Exactly, and the local variations in those areas. And so the payment guide is exactly that. It's simply a guide of the kinds of services where there are ways of covering, paying, coding for these areas, but it has to be done, and customized, for your particular circumstance.
Yeah. Thank you, Dr. Jonas. If you would just mention the website, your website
Yeah,
again.
So very simple. It's called Healing Works Foundation. You unfortunately got to spell it all out, healingworksfoundation.org. And there is, some buttons for general medicine. There's one in oncology, because we've done a big effort and again tested these tools and customize these tools for the care of cancer patients in those areas. And there's also a link if you want to train your patients or educate your patients about these areas, where your patients can click and go to a landing page which educates and talks to them and gives them resources about what is whole person care, right, so that they come in understanding and prepared how to do it. So healingworksfoundation.org.
And thank you for your service, for your care of all these patients, for educating us this hour, and thank you to the listeners. And I hope you'll find some of the other resources as helpful as I did. I'm going to hand it back to Alec.
Awesome. Thank you, Dr. Brown. Before we wrap, Dr. Jonas, did you want to go over any of these next 3 slides you have on the deck?
I can just show them too, for those that are hanging in there and would like to see them. Just a couple things. Let me just see if I can make this happen. Here we go. It's not working. Can you hit the next slide button? Mine's not. Doesn't seem to be advancing.
Right now we got it on the data collection slide. Apologies if it's frozen for you.
Oh, well, okay. Mine is showing, I must be frozen, because I'm still on the question slide. So I can't see it. So There's a data collection which shows 4 types of data's categories that you can draw from in those areas. So these are the quintuple aim. These are the basic things from the types of outcomes that you might want to measure in your practice improvement program. And again, if you go to our website, we have examples of metrics in each of those categories that you can select from, again, depending upon what your system wants to track in terms of its improvement program. So we have specific metrics that are the usual types of metrics in each of those categories. So if you go to the next slide, what is it showing?
The E5 with the QR code.
PHI.
Yeah, so these are this is the electronic PHI, the electronic personal health inventory, for those practices that may not want to go to the trouble of or not able to embed this in their electronic medical record. You can go there and automate this. So you can track that, you can send this to the patient ahead of time, they fill it out, it populates the key questions for the discussion, and then you go in and you have the visit, you can actually populate it at the bottom, and then you can import it into the electronic medical record in those ways. So it's simply a simplified way of electronically capturing this data with patients ahead of time, or if you're doing this through televisits, which I do through televisits all the time, then this is an efficient way to capture that information electronically. And then was there another slide?
And then finally, we have your contact info about HealingWorks Foundation and all your CME courses and such.
Okay, yes, there is a CME course on this, a couple of them, one on chronic pain, one on primary care. Were developed by Medical Education Center at Tufts University. It's freely available. The foundation supports, the CME costs of that. So your team can kind of go through that. They can get credit for it to learn how to do this before you begin to look at how you would put it into your system.
Awesome. Well, thank you both for your time and your expertise. Next, if you're looking for something a little more interactive, we would like to invite all attendees to join us in person for our next Steps Forward boot camp. You can learn about best practices from top physician experts through interactive activities, through thought sharing, tactical strategy breakdowns, and how-to examples. Our boot camps equip attendees with the time-saving tools and strategies needed to reform their organizations and enhance professional satisfaction. Registration for our upcoming boot camp on September 17th is open now. And if you have interest in attending or wish to learn more, scan the code on the slide right now. As a reminder, today's slides and related resources are all available for download from the resources widget on the right side of your screen. And for additional resources to support your physicians and staff, please visit the American Medical Association website or stepsforward.org. Thank you folks so much for joining us, and we hope to see you again soon.